Hi, I'm Dr. Vidushi Sharma from Suvi Eye Institute, Kota, Rajasthan in India. And in this video, we demonstrate the technique of the use of botulinum toxin injection for the treatment of hemifacial spasm. The same technique is of course also used for the treatment of blepharospasm by the use of botulinum toxin injections. Now in this case here, we are using the product Botulinum, which is a botulinum toxin type A available in the Indian market by a vaccine making company by the name of Biomed. This has been used by us for almost 2 to 3 years now and has given very good results. So as you can see here, this patient of about 50 years of age has severe hemifacial spasm affecting the left side of the face. The spasms were very frequent in this particular patient to the extent that it was difficult for him to carry out his routine task because of the constant irritation of the twitching movements. Now, as we all know, hemifacial spasm is characterized by the abnormal twitching and movements of the facial muscles on one side of the face that are supplied by the facial nerve. The eye is very prominently affected because of the orbicularis muscle, and also some patients have muscles affected on the cheek and the mouth also, and therefore they may have retraction of the mouth along with the frequent closure of the eyelid as seen here. While in blepharospasm, it is both sides that are normally affected, though one may be involved more than the other, and it is mostly affecting the orbicularis oculi, that is the muscles around the eye, which have an involuntary forced repetitive closure of the eyelids, and the patient does not have control and finds it difficult to open them when he suffers an attack of these spasms. Now this is the Botulinum that is available, and this comes in the standard packing with a freeze-dried preparation of the botulinum toxin in one vial and the normal saline for reconstitution in the other vial. Now for the initial treatment, we use a 50 unit vial. The diluent is first taken into a syringe. Different surgeons and ophthalmologists or neurologists have different preferences for the amount of fluid to be used as a diluent and the final concentration that they want. What we have used here is 2 ml of normal saline to reconstitute 50 units of botulinum toxin, which gives us a final concentration of 2.5 international units of the toxin in each 0.1 ml of the reconstituted solution. So the normal saline is taken into a 2 ml syringe, and this 2 ml of diluent is then placed into the vial containing the freeze-dried preparation of the botulinum toxin, and the vacuum inside the vial automatically draws the fluid inside. Normally, most of the powder would dissolve in the diluent on its own. Vigorous shaking is to be avoided as we do not want to agitate the solution and form too many bubbles. A small degree of bubbles are normal in such powders and are common and do not have any bearing. We then draw this fluid into a tuberculin syringe depending on how much we want to inject, and most commonly we use a 30 gauge needle to inject so that it is minimally painful. The dose per site is also quite variable, but the normal recommended dose is anywhere between 2 to 5 international units per site. We normally start with a dose of 2.5 international units at each site. This is also very convenient because with the reconstitution that we had, where the 50 unit vial is reconstituted with 2 ml of saline, the final concentration is 2.5 international units per 0.1 ml. Therefore, at each site we need to inject 0.1 ml from the tuberculin syringe. The normal sites of injection again vary from doctor to doctor. Different neurologists and ophthalmologists have different protocols as to where to inject. The central part of the upper eyelid is to be avoided as it causes more incidence of ptosis as a complication in the post-injection period. Also, the medial part of the lower eyelid is avoided as it is thought that some of the toxin may diffuse and affect the inferior oblique muscle, causing diplopia in these patients. Some people also inject the site above the eyebrow, but here we inject 2 sites just below the eyebrow, 2 sides medially and laterally on the upper lid and the lateral canthus, and also inject the lateral part of the lower eyelid. In cases of hemifacial spasm, we also inject in the cheek after observing the area where the muscles are most active. The area just around the lips is to be avoided, as this can cause paralysis of the orbicularis oris on that side, which may lead to drooling of saliva in the post-injection period, which the patients are very uncomfortable with. We mark the injection sites with a marking pen, and we then inject with the needle kept tangential. We do not want to keep it perpendicular because the injection is to be placed just near the superficial orbicularis muscle. A deeper injection would place the toxin nearer to the levator palpebrae muscle and cause more ophatosis in the post-injection period. These injections are hardly painful when used with a 30 gauge needle. After the injections, the patient can get cold ice packs if there is any problem, and this is the patient after the injection after a week, where we do observe a mild ptosis on the left side, but the patient does not have any hemifacial spasm at all and is very comfortable with the results. The ptosis is a very frequent complication of botulinum toxin injection. In many studies, the incidence of ptosis has been reported to be as high as 45%. Most of the patients, the ptosis recovers in about 2 to 3 weeks, and considering that these patients were severely incapacitated before the injection, they don't really mind the ptosis unless they are very cosmetically conscious. So to summarize, botulinum toxin is a very effective treatment for cases of hemifacial spasm and blepharospasm, which are sometimes severely incapacitated by their condition. The injection provides prompt relief and lasts anywhere from 4 to 6 months. Some patients have a lesser incidence of this problem after the injection, but most patients come back to their pre-injection position in a period of 8 to 10 months, necessitating a repeat injection in many cases. All the patients must also be explained that they may have certain transient side effects like ptosis in the post-injection period. There can also be cases where the lid may turn a little outward or inward, causing irritation, but all of these side effects are transient and would resolve on their own by 2 to 3 weeks. Most patients are quite happy and satisfied with their results, and along with the Botox, this newer preparation of Botogenie available in the Indian market can also be used, which is cheaper than the Botox available. Thank you very much.